Moving on to the next motion, and the next motion is cataract surgeon. It's related to the one that we've just discussed. Cataract surgeons should never ever do medical retina. And we will reverse the order slightly in this. We would invite the speaker who is going to speak against this motion. She is none other than our very own Dr. Bharti Kashyap from Ranchi, Jharkhand. Ma'am, please start sharing your screen. Nothing to introduce her. She is going to electrify this whole session, I'm sure. And if it does any help to the flow of ma'am's talk, ma'am, can you please start sharing your screen if you're there?
Doing.
Yes. So I'm very wary of Dr. Bharti's presence all around because she's already defeated me once in a debate back in 2014, if I remember right. So ma'am, are you ready? Here goes the...
Am I audible?
Absolutely audible, ma'am. There cannot be a situation where you're not audible.
Okay.
Your time starts now, ma'am.
Okay. So good morning, everyone. My topic is cataract surgeon should never do medical retina, against the motion. Yes, of course. Every cataract surgeon, not only the cataract surgeon, must do medical retina. What does the law say? See the MCI guidelines to the various institutions having ophthalmology. The format for practical clearly shows that 70 marks out of 150 are for retina cases, and they must know intravitreal injections. MCI has made medical retina teaching mandatory for all postgraduate students. The degree is not only meant for decorating the walls of your clinic, but to be of use to common public. If not medical retina, they should not be allowed to handle even other subspecialties. In our country, more than 18% is contributed by diabetic retinopathy and AMD. Leave aside other retinal diseases. We need to screen 5 million babies per year for ROP, 65 million elderly for AMD, and more than 80 million diabetics for diabetic retinopathy. Out of this 80 million diabetics, 20% of these have some form of retinal involvement warranting treatment. These are the various studies quoting the same. About 30% of the cataract patients have AMD at the time of cataract surgery. See the other retinal comorbidities with cataract as shown in this table. Can 1200 VR surgeons handle just one of the diseases among ROP, diabetic retinopathy, and AMD alone? Leave apart the cumulative load. It is a big no. 70% of our population is in rural area, while 30% of doctors are in rural area. Availability of VR surgeon in rural area, almost zero. So it means these all patients have to travel so far. More than 80% of travel of the rural population is for medical reason. Do you really want the rural to suffer that much? So look at the India's poverty profile. 1/5 of Indians are poor. That is almost 27 crores. 75% of them earn less than 5,000 rupees per month. Can they afford all these VR surgery costs? It is not only the procedure cost, traveling time, lost working hours, accompanying person stay. In case of emergency, like endophthalmitis, just delay because of the travel time would mean a panophthalmitis. Women in the West, when in Western world, OR nurse can inject intravitreal injection. Why not at least we anterior segment in our country, in India, we can do it. We need to learn from this pandemic. Big hospitals meant for cardiac and other specialties were converted into COVID center. See, we doctors, forgetting the barrier of specialty, stood up to the challenge of pandemic and treated COVID patients with otherwise is a domain of specialists. Right from the medical intern to head of the department rose up to the occasion. So think beyond self and let others distribute your work. Thank you.
Thank you so much, ma'am. It would have been really interesting to find out how this vibrant presentation was going to be countered. But unfortunately, I mean, this probably with a query mark might make you happy, Bharti ma'am, but Dr. Mamta Agarwal, who was supposed to speak for the motion, has not been keeping well, so she pulled out, and we learned about this morning, so we did not have any time to arrange for an alternative. The onus was on me to speak for the motion, but I said not the second time. definitely not. I'm not going to lose to her again. So Sneha, I think we would just take an extended panelist view on this, and let's see what the panelist has to offer as an opinion for or against. Dr. Bharti is definitely visibly happy. So over to you.
I wish her good health.
I know.
I wish her good health.
I know, ma'am. I know.
Yes,
It's just in light of it, right? Yeah.
Indeed, a topic which has divided a lot of cataract surgeons, and medical retina is soon becoming the go-to field for all cataract surgeons to add to their armamentarium. We will take a quick opinion here from Dr. Sahebaan Sethi, who is a glaucoma specialist. But we want to know, medical retina, is it the right of every cataract surgeon in today's world?
Thank you, Dr. Sneha. There were very interesting points put by Dr. Bharti. But in my personal opinion, it's not so much about what you can or cannot do, but it has a lot to do about where you were trained, how you were trained, and also where you live, the demographics of your area. So I think in a rural setting, it makes sense for anterior segment surgeons to divulge into posterior segment limited, whether it's medical retina, lasers, intravitreal injections, because for them, demographically, for the patients to probably travel so far, if your vitreoretinal surgeon is about, say, an hour away and visits you just once or twice a week, it probably makes sense to learn that skill and give the patient immediate attention when required. On the other hand, in an urban setting, I don't think it will be feasible, because with the kind of expectations patients come with and the state-of-the-art treatments that you want to deliver to your patients also, having a VR surgeon or a trained medical retina right next door, I think you would want to ask yourself again whether you really want to take up their job if you're not trained well in it. But I think the one advantage of doing anterior segment and medical retina together would be the fact that you're not putting all your eggs in one basket. So, tomorrow if, say, cataract surgery runs out of business, when there are drops invented which do away with cataract surgeries altogether, or if you're just a LASIK surgeon and your procedure replaces it, then what do you do? So if you do little bit of everything and you do it well, then maybe you're better off doing it. But at the same time, you have to have very good relationships with your VR surgeon, because if something goes beyond your skill and you can't handle it, then you have to have them on board. And I think also a lot has to do with the training, and people who were probably trained in the 90s, they are a lot more comfortable in dealing with so much more, because they were trained such. And nowadays our postgraduate programs don't really train you in giving lasers or intravitreal injections, no matter what you say. So, especially going ahead and doing a medical retina fellowship just so that you're able to equip yourself with all those skills probably makes sense in a rural setting. Yes, of course.
Thank you so much, Dr. Sahiba. If we can take one more quick opinion, Dr. Bharti has asked a very important question here. With the increasing load of medical retina disorders in India, can our VR surgeons alone handle it without the help of cataract surgeons? Dr. Ashok Rangarajan, can we have your opinion on this, please?
Thank you for calling me in. Again, personally, I did an anterior segment fellowship and then was trained in medical retina in Shankar Netralaya, where I was in the retina department before I quit Shankar Netralaya. So I'm a trained medical retina person. Now, the opinion here which I have is, it's not about whether a cataract surgeon can give an intravitreal injection or not. That is not medical retina. I feel anybody who wishes to claim himself to be a medical retina consultant should be trained in the practice of examination and interpretation of the various investigations of retinal disorders, and know and not hesitate to take a second opinion when required. Yes, so thereby the need of the country is that all ophthalmologists have to chip in. But that is where probably we are solving that problem by doing teleophthalmology and artificial intelligence, where we are able to do all these imaging and have less number of trained ophthalmologists screening for those patients to solve that problem which Dr. Bharti raised. But the important take-home message here is, should only vitreoretinal consultants do? No, there is a subspecialty branch. Let me also tell you that any vitreoretina consultant, if you look at his practice, who is not doing other specialties, is doing majority work is medical retina. So only a smaller fraction of the retinal practice is surgical retina practice. So the need for medical retina specialists are more, but let everybody who's interested get properly trained in respective centers in their region and then practice. And more important than that is not hesitate to take a second opinion as and when required.
Once again, hitting the bullseye, Dr. Ashok, exactly what I had in mind. I mean, if you cannot treat, at least can diagnose, look at the retina, so nobody stops you from there. Righto, moving on.